Okay, hello and welcome to our last SPHN virtual brown bag of the academic year. Contrary to what it says as the organizer here, I am not Kate Sweeney. I'm Megan Robbins here at UC Riverside, and I'll be your moderator for today. We're finishing up with a leading expert in the field of cardiovascular and psychological research, Dr. Thomas Kmark. Tom is a professor of psychology and psychiatry at the University of Pittsburgh who investigates psychosocial stress and cardiovascular disease and is an expert in methods such as ambulatory blood pressure, ecological momentary assessments, and cardiovascular reactivity. So he's very highly regarded in his field, and we're very lucky to have him as our speaker today. But before I hand it over to him, I'd like to first orient you to the webinar functions. So Tom has indicated that he's very interested in handling any and all of your questions that you might have. And so if you look over to the panel for the webinar that you have here, you should see a virtual sort of hand-raising function so that if at any time you have a question, you can click that button and I'll make sure it gets answered. But if you don't want to do that, you can also send a chat message to me or to everyone. So if you look towards the bottom, it says chat, and you have a drop-down option of to whom you send your chat message. So you can send it to everybody or just me as the organizer. I would ask that you don't just send it to Tom so he can focus on his presentation. I'll be fielding the questions, so I'll make sure that they get answered when in good order. So without further ado, I'd like to hand it over to Tom.
Thank you, Megan, and thank you for inviting me to present. As Megan indicated, I'm very interested in responding to your questions and concerns in putting this together. I am orienting people at a very basic level, but I'm happy to ramp it up in either direction depending on where your issues are. So please do feel free to use the chat button or however you need to participate. So the first question that occurred to me that would be important to answer in this kind of webinar would be, why assess cardiovascular variables in psychosocial research? So for example, why am I interested in these variables? Well, one first reason why this might be an important issue for people is that blood pressure and heart rate are complex markers of autonomic nervous system functioning, and they have implications for cardiovascular risk. So we know that resting blood pressure, for example, is a very strong risk factor for cardiovascular disease, and heart rate is actually a risk factor as well. So people with lower resting heart rates are at lower risk for disease outcomes. So we might be interested in psychosocial factors in resting cardiovascular function. So that might be one reason to be interested in these variables. Secondly, there are a variety of different ways of looking at changes in cardiovascular activity across tasks and settings that can also have implications for helping us understand pathways of influence linking psychosocial variables with cardiovascular disease. So many of us are familiar with the concept of cardiovascular reactivity that we will be touching on today, which is basically looking at changes in cardiovascular function from a resting state to a stress state. But there are other kinds of comparisons between states and settings as well. For example, the concept of white coat hypertension, the notion that people can show larger blood pressure than they should show in a clinic setting because of the presence of a high status medical person who's taking the blood pressure, and that can have implications that can introduce confounds in terms of assessing risk for cardiovascular disease, and there are some people that are interested in psychological factors that may affect that phenomenon. There's the issue of ambulatory versus clinic blood pressure, and this is something else we'll be touching on today. Blood pressure may be somewhat different in an ambulatory setting than a clinic setting. We know that ambulatory blood pressure is a stronger predictor of disease risk than clinic blood pressure, so we may be interested in some of the psychosocial factors that account for these discrepancies. And then finally, blood pressure dipping, which refers to the difference between blood pressure during daily life when people are in a waking state versus when they're asleep. And there's a lot of evidence that a great deal of the portion in ambulatory blood pressure a portion of the variance in ambulatory blood pressure and its association with cardiovascular disease is accounted for by reduced blood pressure dipping. That is, people who have higher 24-hour ambulatory blood pressure frequently have this because their sleeping blood pressure doesn't decline as much as they might want it to. And so there are people that are interested in psychosocial factors that affect blood pressure dipping. And this is another pathway by which psychosocial factors can influence disease risk. A third reason why people might be interested in cardiovascular variables in psychosocial research has to do with issues that are specific to cardiac patients. And we're not going to be covering these issues as much in today's seminar, but I put a reference here that you might be interested in that pertains to mental stress ischemia and various ways of assessing the effects of mental stress on ischemia in the heart. In cardiac patients, we know that there are changes in cardiac function that have relatively direct impact on risk for acute events, that is, arrhythmia and ischemia. Ischemia is the state of oxygen deprivation, or a state of where the vessels are not delivering oxygen sufficient to meet the metabolic needs of the individual, and a lot of that is secondary to the atherosclerosis, plaque in the arteries, but it's exacerbated by acute mental stressors. And the extent to which it's exacerbated by acute mental stressors may be associated with the extent to which people are at increased risk for acute coronary events. So there's a very active literature looking at psychosocial factors that affect these kind of acute changes in cardiovascular outcomes in cardiac patients as well. And one thing that I wanted to caution people about in terms of an interest in cardiovascular function is that it is clear that there is a very direct communication and perhaps a bidirectional communication between the heart and the brain. The heart is under neural control, but it's important to be cautious about using cardiovascular measures as a window to our mental states. I think it's tempting sometimes for us to be thinking about all measures of autonomic nervous system activity as if they're kind of direct indices of stress or anger or anxiety and so forth. And I always have to remind myself that the cardiovascular system is designed to assist the body in meeting metabolic requirements, not to reveal emotional states. So that the effects of stress on, for example, on cardiovascular changes, acute cardiovascular changes, is context specific. So a person, for example, who is doing a public speaking task may show an increase in cardiovascular activity, whereas a person who is afraid of having their blood drawn may show a decrease in heart rate, kind of a parasympathetic response when the needle is poking them. Both of them are experienced by us subjectively as fear, but they have very different cardiovascular implications. So the effects of mental states on cardiovascular activity are context specific. And then the second reason to qualify this link between mental states and cardiovascular activity is that behavioral demands are just one of the many determinants of cardiovascular activity in any given situation. So that we know that I have to think about this a lot with my work with ambulatory monitoring. We know that posture and physical activity and substance use and temperature and whether or not a person is talking, all of these things have an influence on ambulatory blood pressure, in addition to the specific, perhaps, psychological state that I may be interested in studying. So that's my caution here in terms of we want to think about reasons for studying cardiovascular activity in our program of psychosocial research, but we want to make sure that we're not equating cardiovascular activity with specific mental states. So I'm just going to jump in here and give a really rough overview of cardiovascular physiology, which will come in handy a little bit later when I'm talking about the role of the autonomic nervous system and the various components of cardiovascular activity that we can study in the laboratory in the field. So bear with me if you're familiar with this. So the heart, as you may be familiar, is composed of 4 pressure-activated pumps. So there's the atria in the top, the left atrium and the right atrium, and the ventricles in the bottom, the left ventricle and the right ventricle. And the atria are holding stations that receive blood from the cardiovascular system. It's kind of the input part of the system. And then the ventricles are responsible for pumping the heart through the body. So the right ventricle pumps the heart into the pulmonary artery and into the lungs where it's reoxygenated, and then it returns into the left side of the heart. The left ventricle pumps it to the system as a whole, and it delivers the oxygen and nutrients to our cells. The right and the left side, we think of them as operating sequentially, but actually they operate in parallel. So you have the atria pumping first, and then the ventricles pumping, and that's the lub-dub, lub-dub, lub-dub that you hear the heart sounds as the atria and the ventricles pumping. There are several kinds of vessels in the body that deliver the heart to the tissue. First of all, we have the aorta, which is the main vessel that comes out of the left ventricle, and then you have the arteries, and then you have the arterioles here. Now, the arterioles they're a muscularized set of vessels throughout the body. I think of these as being throughout the skin and throughout the digestive tract and so forth. And they're innervated by the sympathetic nervous system. And so let's see if I can. Okay. Oh, all right. I forgot to mention here, when we're talking about the pumping action of the heart, the pumping action of the heart starts at the sinus node, which is in the right atrium. It's there's an electrical, there's a system of electrical conduction that feeds the heart, and that system of electrical conduction receives input from both the sympathetic nervous system in red, which speeds up the heart, and the parasympathetic nervous system in blue, which slows the heart. We'll come back to that in a minute. When we get to the arterioles are innervated by the sympathetic nervous system, and so that they are also under autonomic nervous system control. The branch of the sympathetic nervous system, as it were, the receptor types that are sensitive to sympathetic input at the sinus node are called beta sympathetic receptors, and the types of receptors that are responsive to sympathetic nervous system input at the arterioles are alpha adrenergic receptors. So we sometimes think about beta adrenergic activity as involving the kind of the pumping action of the heart, and the alpha adrenergic activity as involving the vascular constriction in the heart. After the arterioles, we have the capillaries that are that's through the capillaries that the nutrients and the oxygen flow. Then we have the venules and the venous side of the heart that returns the blood to the atrium. So when we're talking about measures of cardiovascular function, there are a number of different ways we can look at cardiovascular function. There's heart rate, but the important thing about all of these measures is that they all have complex determinants. Very few of them are kind of pure measures of one one kind of branch of physiology. So heart rate, as I mentioned, is influenced both by the parasympathetic as well as the sympathetic nervous system. As it turns out, the parasympathetic nervous system plays a larger role when the heart is at rest, and the sympathetic nervous system plays a larger role during activity. And then you have what's called stroke volume. Stroke volume is the amount of blood that's pumped out of the heart with every beat, and this is determined in part by the sympathetic nervous system, as I mentioned. But it's also determined by the amount of venous return to the heart. So there's a kind of a self-regulatory system in the heart. The amount of blood that's pumped back to the heart stretches the atrium, and that has the effect of, or stretches the ventricle actually, that has an effect of increasing the so-called contractile force of the heart. That's also another important determinant of stroke volume. Cardiac output is a joint function of heart rate and stroke volume. And then you have this concept of total peripheral resistance, which has to do with the extent to which those arterioles in the digestive tract and the skin and to some extent in the skeletal muscles are constricted by the role of the sympathetic nervous system, and total peripheral resistance is abbreviated TPR. And then you have blood pressure, which is a joint function of cardiac output and TPR. So it's the amount of fluid in the system, and it's the extent to which those vessels are constricted. So you can kind of think about when you step on a garden hose, the blood comes out, or hopefully not blood, the water comes out with greater force. So it's both the amount of fluid, the degree to which the spigot is turned up, and the amount to which you're stepping on that garden hose that determines the amount of pressure. Same thing with the cardiovascular system. Okay, so we're going to walk through each of these functions that I just described and talk a little bit about how to measure them. So heart rate is usually measured using an electrocardiogram, which is abbreviated EKG from the German. And it's most simply assessed using a kind of 3 sensors which are placed on the body. And 2 of them, the heart needs to be in between 2 of them, and then the third one is the ground. It can also be assessed by putting a sensor on each wrist and the ground on the ankle. But usually in the cardiovascular psychophysiology laboratory, we put the sensors on the chest so that they are minimally affected by movement artifact. So here's just a visual of what the kinds of sensors that we use in the laboratory, and this is what an EKG looks like. So basically what we're looking like is what we want to do in placing these electrodes is we want to maximize the magnitude of the R wave. So this is basically we're trying to, most programs are triggered that measure heart rate are triggered by the R wave, so we want to maximize the magnitude of this visual feature of the EKG if the main thing we're interested in is measuring heart rate. So heart rate can be measured in beats per minute. So for example, 60 beats per minute. And then it can also be converted to what's called interbeat interval, where we discuss the interval between each R wave in milliseconds. So 60 beats per minute is equivalent to 1,000 milliseconds in interbeat interval. And that's important because it's a more sensitive measure. And when we're measuring heart rate variability, we start out with interbeat intervals, and then we're looking at the extent to which these interbeat intervals change over time. So I mentioned that heart rate is jointly determined by sympathetic and parasympathetic nervous system determinants. One of the ways to capture the variance in parasympathetic nervous system input controlling the heart rate is through assessment of heart rate variability. As it turns out, heart rate changes with each beat of the heart, and it changes in a cyclic manner in conjunction with the respiratory cycle, so that heart rate speeds up during inspiration. As you can see in this diagram, it's relatively rapid here, and then it slows down during expiration. And the term for this is respiratory sinus arrhythmia, the asynchronous changes in heart rate with that are conjunction with the respiratory cycle. And physiologic, so it's called respiratory sinus arrhythmia, respiratory because it has to do with breathing, sinus because it has to do with the sinus node that controls the rate of the heart. And physiologically, it's thought to represent an efficient strategy that minimizes heart rate during the period of the respiratory cycle when perfusion is at its ebb. So while we're expiring, the blood is not as oxygenated, so there's no reason to expend the extra energy in terms of the heart rate. And Changes in parasympathetic activity to the heart are what account for this respiratory sinus arrhythmia. There's more parasympathetic activity to the heart during expiration and less during inspiration. And some of these changes appear to be driven by central respiratory generators in the brain, in the medulla, whereas some of these are driven by pulmonary stretch receptors. It turns out there's individual differences in the extent to which heart rate differs during inspiration versus expiration, and those individual differences can be used as a marker of parasympathetic input to the heart. To the extent that there's a very large change between inspiration and expiration, the person can be inferred to have more parasympathetic input to the heart in general, and if there's smaller changes, then there's smaller parasympathetic nervous system activity. Measures of respiratory sinus arrhythmia vary as a function of central nervous system input, but they also may vary as a function of input from the lungs. So when you're measuring these differences, there's actually a big controversy in the literature about whether or not you need to measure respiration directly. Some say it's not that important, others say it is. So my advice would be probably it's best to measure respiration when you measure heart rate variability in order to be able to satisfy the critics that may have some concerns about it. So sometimes, you can both measure the respiration, and then you can also do a paced breathing task while you're measuring the heart rate variability in order that everyone is facing the same kind of respiratory demands while it's being measured. And Tom Ritz is one of the leading experts on the role of respiration in its terms of its contribution to respiratory sinus arrhythmia. So here's a reference there. Okay, so how do we measure heart rate variability? We can measure it with what's called the beat to trough method, which is simply measuring the average heart rate during the, I'm sorry, this should say peak to trough method. During the peak of inspiration, what's the peak heart rate during inspiration, and then what's the trough or the lowest heart rate during expiration, and just average this across a number of respiratory cycles, and we have kind of a different score. Paul Grossman has kind of developed this method, and this is identified with him. Second method for analyzing heart rate variability is through spectral analysis. And in spectral analysis, so what we're doing here is we're looking at the power, we're looking at the kind of the variance in heart rate variability that's attributed to high frequency variation, and high frequency variation is associated with the parasympathetic input. So the total variation in heart rate, we're looking at that the proportion of that variance it's attributed to the high frequency variation. That is the kind of more rapid fluctuations as opposed to low frequency variation. Low frequency variation is thought to be more controlled by the sympathetic nervous system activity. However, that equation is less clear than the linking of high frequency heart rate variability with parasympathetic. So some folks say that we can measure sympathetic variation, sympathetic nervous system using heart rate variability as well by looking at using in a spectral analytic equation the ratio of low frequency to high frequency heart rate variability. But that is a little bit more controversial. The least controversial is using high frequency heart rate variability for measuring parasympathetic input to the heart. So which is better, peak to trough or spectral analysis? I think I'd have to say that the consensus seems to be, even though it's more complex, that the spectral analytic approach is more precise. And so I've put here a reference from the MacArthur Network that you may find useful on the web, describing the utility of measuring respiratory sinus arrhythmia. So what does high-frequency heart rate variability signify? Well, it's important to be to not draw too general conclusions about what high-frequency heart rate variability means, at least from where I sit. Dick Jennings wrote a nice editorial in Psychosomatic Medicine a few years ago where he was critiquing an article that was looking at high-frequency heart rate variability and was correlating it with gastrointestinal systems. The vagus, the parasympathetic nerve, is relatively selective in terms of the extent to which it is active in different effector organs. So we may or may not be able to draw conclusions about what's going on in terms of vagal input to the rest of the body based upon vagal input to the heart. And so that's one thing to consider. So people have shied away from using, in recent years, using high-frequency heart rate variability. They've shied away from the term vagal tone because it implies that there's kind of a unitary vagal tone throughout the body, and that may not be entirely accurate. Another issue has to do with the extent to which we can draw inferences about what's going on in the brain as a function of high-frequency heart rate variability. And there's a very large literature, actually. There's a number of developmental psychologists, such as Nathan Fox and Steve Porges, who are interested in looking at heart rate variability as an index of self-regulation. There's a variety of reasons why they think that it may be a marker for self-regulatory ability in general. And Julian Thayer is another researcher who is of this school, and he's published recently a really nice meta-analysis looking at the relationship between heart rate variability and the centers of the brain. This is on an individual difference basis that are most active. And so he's interested in thinking about heart rate variability also as a kind of a marker of dispositional differences. I'm not that familiar with that literature. Again, I just think it's important to be cautious and to make sure that we don't we don't jump to conclusions. For example, one of the things we know is that people who have more parasympathetic input to the heart, it's also a marker of physical fitness. So it may be that people who are better off in a variety of different ways are more physically fit and also have better self-regulatory ability. Whether we can infer, whether we can use heart rate variability then as a kind of causal marker of this self-regulation or an effect, a direct effect of this self-regulatory ability, I'm skeptical about, but I have to confess that I haven't thoroughly reviewed this literature. In addition to thinking about varying with respiration, heart rate also co-varies with blood pressure in an interesting way. And there's something called the baroreceptor reflex. It involves receptors that are located in the aortic arch of the heart as well as in the carotid artery sinuses. And these receptors, when they help us to modulate blood pressure within a relatively constant range. The baroreceptor reflex is triggered when blood pressure moves out of the expected range, either higher or lower. If blood pressure it becomes too high, is kind of out of range is at the high end of the range. These reflexes trigger, and they operate under medullary control, and they result in increased parasympathetic input to the heart, which slows the heart rate. Likewise, if blood pressure is relatively low, it may result in a reduction in parasympathetic input to the heart, which would result in a heart rate increase. So the baroreflex sensitivity has been most useful is in cardiac patients as a risk stratification index. For example, in animal models, it's been shown that baroreflex sensitivity is protective against arrhythmia, in some cases fatal arrhythmia, in dogs that have been given that have been given kind of cardiac lesions. So I didn't mention this explicitly, but there are individual differences in baroreflex sensitivity. So some people have greater sensitivity than others, and it's thought that that is kind of a resource, especially among cardiac patients, and may actually be predictive of sudden cardiac death in some instances. So you may ask, well, if we have these kind of regulatory influences on the heart, why is it that people develop hypertension? It turns out that probably a larger contribution to a person's resting blood pressure, whether it's hypertensive or normotensive range, has to do with what's happening with kidney function in terms of the fluid in the body, and also what's called the renin-angiotensin system, which is a hormonal system that affects sympathetic nervous system activity. So it's more to do with the kidneys and related issues than it does with baroreflex activity. Baroreflex activity has more to do with kind of short-term regulation of blood pressure and heart rate control. Okay, so we're going to move on to blood pressure. Are there questions? Have I missed any questions, Megan? Can everybody hear me?
Sorry, I had to unmute myself. No, there aren't
okay.
any questions just yet. Go ahead.
Okay, all right. I'll keep going, and you let me know. I've been in some of these things sometimes where a person gets disconnected somehow, and nobody finds out until later. So I'm glad to check in.
You're loud and clear, yeah.
Okay, so I want to talk a little bit about blood pressure and how we measure blood pressure. The gold standard for blood pressure really involves pressure transducers placed in the aorta. So that is considered the best way to measure blood pressure. Obviously, it's an invasive method. It's not recommended for casual assessment. And the pressure in the aorta varies over the course of the cardiac cycle, with the peak pressure coinciding with the moment that the left ventricle is ejecting blood into the aorta. That's the period of the cardiac cycle that we call systole, or systolic pressure. And the lowest pressure coincides during the period when the pressure-operated valves between the left ventricle and the aorta are closed. And that would be diastolic pressure. That's the part of the cardiac cycle called diastole, or diastolic pressure. So these are the measures we're accustomed to, systolic blood pressure and diastolic blood pressure. And we usually measure them in the brachial artery on the arm as an indirect way of getting into what's happening with central blood pressure in the aorta. And pressure is conventionally measured in millimeters of mercury, because the conventional so-called sphygmomanometer device assesses cuff pressure based on the extent to which it's associated with elevations in a mercury column along an enclosed glass tube. So conventional blood pressure measures are auscultatory. That is, they're detected by sounds, in this case called Korotkov sounds, in the artery. And these are sounds that are made by turbulence in the blood when the artery is partially occluded by an inflated cuff. And the peak sounds occur when the pressure of the cuff, let's see, I think the next one shows this. No, that's the peak sounds occur. Oh, here we are. The peak sounds occur when the pressure in the cuff are highest, and then the lowest. The sounds disappear when the pressure in the cuff reaches the diastole. So that the K sounds are how we detect auscultatory measurement. Automated blood pressure measures are now used more frequently than these traditional devices. Some automated devices continue to be auscultatory. That is, they use microphones to detect the K sounds in the artery. More commonly, though, is for automated devices to be what's called oscillometric. And oscillometric blood pressure, and that's because oscillometry detects blood pressure using a pressure rather than a sound transducer, and the peak pressure oscillation is detected during the the period of during the period of cuff deflation, and so this is the peak pressure gradient between kind of high and low during the cardiac cycle, and then based upon this, this peak pressure that's detected with oscillometric devices, systolic and diastolic blood pressure are indirectly detected using an algorithm. So that's an important thing to realize. Oscillometric measurement is what we typically use nowadays to measure blood pressure both in a clinic and in an ambulatory setting. But we're using this to estimate systolic and diastolic blood pressure in the brachial artery, not to measure it directly. So most blood pressure devices will assess blood pressure in a periodic manner, for example, every minute or two. There are also devices that will assess blood pressure on a continuous basis, beat to beat. There's really no reason, in my estimation, to take beat-to-beat blood pressure unless you're interested in issues like baroreflex sensitivity. Because when you're looking at baroreflex sensitivity, you're interested in looking at how blood pressure and heart rate are correlated with each other on a beat-to-beat basis. So measures of continuous blood pressure have traditionally had a lot of problems with them. For example, because the brachial arteries can't be occluded continuously over long periods of time, measures of continuous blood pressure are usually based upon blood pressure that's measured in the fingers or the wrist. And so these involve some technical challenges. And they've gotten better over the years. So modern devices are better than they once were. They're quite expensive, though. So this is, for example, a picture of the phenometer, which is kind of one of the gold standard beat-to-beat blood pressure assessment devices. But I'm told by one of my colleagues this is about $11,000. So obviously I wouldn't recommend it unless it's specifically required for the application of interest. So in addition to heart rate and blood pressure, impedance cardiography is a non-invasive tool that's been traditionally used by cardiovascular psychophysiologists for measuring components of cardiovascular function on a beat-to-beat basis. And the impedance cardiography involves the placement of two bands on the neck and two bands around the bottom of the rib cage, and spot electrodes may be used to substitute for these bands. And there are methods that use spot electrodes rather than bands. The outer bands generate a weak, non-detectable electrical current, and there are phasic changes in the resistance to this current over the course of the cardiac cycle that correspond to the amount of blood flow in the thorax. So for example, when there's more blood flow during the systole, there's more blood flow in the thorax, so there's more resistance to the current flow that can be detected by these bands, but not by the person, fortunately. And then during diastole, there's less resistance. So we can look at changes in resistance to this electrical signal over the course of the cardiac cycle, and that's what we have here with impedance cardiography. So the impedance cardiogram is a cyclic waveform that's generated by these cyclic changes. Here's the impedance cardiogram. And then this is the first derivative of the impedance cardiogram, which is generally used for decision-making purposes. And then we look at how the markers on the impedance cardiogram correspond with EKG and heart sounds, the phonocardiogram here. And we look for various characteristic features and what we can do is we can look based upon various parameters that can be measured with this waveform. We can pull out measures of stroke volume, for example, using the impedance cardiography. And then using concomitantly measured EKG, as I mentioned before, cardiac output is a function of stroke volume and heart rate. So we measure stroke volume here, we measure heart rate here, and we can get an indirect measure of cardiac output. And the nice thing about impedance cardiography, it is an indirect assessment, but it can be done on a beat-to-beat basis. So you can look at rapid changes in cardiac output or total peripheral resistance as a function of participating in certain kinds of psychological tasks. So here's stroke volume. Another important A parameter that can be pulled out by impedance cardiography is called the pre-ejection period. The pre-ejection period may be one of the most useful parameters estimated by impedance cardiography. It refers to the period of time in each cardiac cycle when the left ventricle is depolarized, but before the ejection actually begins. So it's roughly right in here. So the left ventricle is depolarized, but it hasn't had a chance. The blood hasn't been ejected into the ventricle yet, and so this is called the pre-ejection period. And it turns out that the shorter the period, the greater the contractile force of the heart. So you're looking for smaller PEPs to correspond with greater levels of sympathetic nervous system activity. So sometimes people will look at high-frequency heart rate variability as an index of parasympathetic activity in the heart, and they'll look at pre-ejection period as an index of sympathetic, especially beta-sympathetic activity in the heart. So those are probably, I mentioned before that most of our measures of cardiovascular function are relatively they involve a number of different kind of underlying determinants. High-frequency heart rate variability and PEP are kind of our relatively purest measures of cardiac function. And what I have here is a reference to an interesting paper that was put out a number of years ago by some colleagues at Ohio State, including Gary Bernson. And this reading talks about using impedance cardiography not just to measure blood flow in the thorax and things like stroke volume and PEP, but also to measure respiration. Usually respiration is measured with a special transducer, a respiratory band around the thorax, but in a sense what we have with impedance cardiography is we already have a band around the thorax. So this reading talks about how we can use our measures of impedance cardiography if we're interested in measuring heart rate variability to get an indirect index, or actually a relatively direct index of tidal volume and respiratory rate that we can use to correct our measures of high frequency heart rate variability as well. So it's a multifunction device. Okay. So in let's see. Some of you may be interested in using cardiovascular measures to assess individual differences in cardiovascular reactivity, and I want to give you some time to ask questions. So I'm going to go through this relatively quickly, and then I'm going to move on to ambulatory blood pressure. So this is a paper that I published with Bill Lavallo a number of years ago that summarizes a lot of the work that I did on cardiovascular reactivity and some of the parameters that influence its reliability and some of my recommendations in terms of what kinds of tasks to use and how to aggregate them and so forth. So let me just refer you to that paper as one perspective on how to measure cardiovascular reactivity. When we're measuring cardiovascular reactivity, we can measure reactivity using a variety of these different parameters we've talked about. Ottaviani et al. Have come up with a unique way that I think is very interesting to measure what they call hemodynamic profile. That is to characterize people as being either high in cardiac reactivity, vascular reactivity, or some combination of the two. So some of us, it's thought, respond to stress with greater increases in cardiac output. Others respond to stress with greater increases in peripheral resistance. And this is, I think, one of the kind of most current ways of thinking about how to measure this stuff, which I think is really novel.
Tom,
so I am interested in...
Tom?
I'm sorry.
Oh, sorry. Sorry to cut you off. You have a question here, so I thought I'd sort of interject.
Great.
One person wants to know, many blood pressure devices also measure heart rate. And she wants to know, are those simple heart rate measurements useful as a measure of stress?
Depending on the context. Remember, it's important not to assume that in all contexts heart rate is a window on mental states. If a person is in a structured setting and you're looking at changes in heart rate from rest to a very structured stress period, you've controlled for other influences like posture and activity, heart rate can be seen as also a measure of responsiveness to that stressful stimulus. So you can look at blood pressure response to the stressful stimulus or heart rate response. And yes, you can use the parameter estimates that are given by the blood pressure device for that purpose. You don't necessarily, if you're not interested in continuous blood pressure, but you have periodic measures that are taken, say, 3 or 4 times throughout a task and at rest, and you're looking at the difference between the two, then yes, that's a legitimate way of looking at reactivity to the stressor. Does that answer your question?
I think it does. So I haven't, I don't know if she submitted it in text. So
Okay.
It sounds like to me like it does. So you have another question here, which you actually, it looks like based on your ambulatory slide, you might be getting a little bit to this, but the question is that you mentioned there are variations in blood pressure due to white coat hypertension and other factors. And they want to know if you can speak more about how the environment and specifically social versus non-social settings can have an impact. And I just got a message from our question asker before that you did answer it, and thank you.
Okay, sure. So one of the things that I'm very interested in, I don't know if this will answer, again, I'll seek some feedback on this. One of the things I'm very interested in, since ambulatory blood pressure is a somewhat better predictor of risk than clinic blood pressure, one of the things I'm interested in is what accounts for that increased variability that seems to be more useful with ambulatory pressure. And one of our assumptions is that daily life contributions to ambulatory blood pressure largely provide greater context for our measures of blood pressure. So folks that have higher ambulatory blood pressure may be at greater risk, in part because they're exposed to more stressors during daily life. So we can measure these things in the context of daily life using ecological momentary assessment, which I've done a lot of work with. And we do tend to see that during periods of both periods of high task demand as well as during periods of social strain during daily life, that blood pressure is somewhat higher than it is during periods in the absence of strain or task demand. In the laboratory, social tasks tend to elicit larger responses than non-social tasks. However, there's no evidence that they're any more predictive of risk than the non-social tasks are.
Wonderful.
So I hope I answered your question.
It sounds like it to me.
Okay. So one of the questions in terms of thinking about ambulatory and clinic is whether ambulatory blood pressure is just more predictive because it typically involves more readings. And we've shown that even if you control for the number of readings, there's something about ambulatory blood pressure that seems to be more predictive, at least for the outcomes that we've assessed. Things to think about with ambulatory blood pressure, this whole issue of the fact that you have multiple determinants of cardiovascular activity comes home to roost because you don't have a controlled setting, so you have to measure all these things. You have to measure posture and activity and substance use. Some of these things can be measured in an automated way, so you can use accelerometry devices, for example, to measure activity and posture to some extent, but some of them kind of need to be measured by self-report. For example, whether someone recently used caffeine or cigarettes. And they also need to be measured in real time because, as it turns out, we have found that a cigarette that's used 5 minutes before blood pressure is taken exerts a much greater impact on that blood pressure value than a cigarette that was 35 minutes before the blood pressure. So you really kind of need to take this stuff in real time and take it seriously if you want to look at psychosocial contributions to ambulatory physiology. In terms of the devices themselves, you want to look at measurement standards for your ambulatory device. And there are a variety of measurement standards. You want to make sure that these are being met. But be careful, because validation criteria, for example, the American Association of Medical Instrumentation validates these monitors. But validation are required at the aggregate level, but not the individual level. So a given person may actually show a fairly large discrepancy between their clinic blood pressure and their ambulatory blood pressure taken in the same setting. And so it's doesn't have to do with setting differences, it has to do with kind of instrumentation differences. And so you need to be very careful to validate. What I try to do is to do a little bit of calibration on an individual basis before I send people out. So I know for whom is the ambulatory pressure reading somewhat higher than we might expect, and for whom are they not? And I try to quantify that. Be aware of the fact with all blood pressure assessments that there's a cuff sizing requirement. The cuff has to be proportional to the size of the arm. Along those lines, there's some people that just can't wear the blood pressure cuffs because their arms are just blood pressure cuffs assume that people's arms are cylinders, and they're not. A lot of us have arms that are more cone-shaped, and that becomes difficult. So some people you just can't use. You can't. Unfortunately, they're just not appropriate for the measurement tool. And then you have to give special instructions to participants in terms of holding their arms still. If you're taking blood pressure at night, you have to make sure they're not lying on the cuff, that their cuff is not, high up above their head and above their heart, and so forth. So there are a number of special instructions. You can't just give people an ambulatory blood pressure and send them out. You have to have some kind of training involved. This is a chapter that a colleague of mine and I wrote a number of years ago that's in this handbook, Physiologic Research Methods in Health Psychology and Ambulatory Blood Pressure. And there's some other very useful chapters in this same volume on impedance cardiography, heart rate variability, clinic blood pressure, and cardiovascular reactivity that I advise you to use this as a resource for as well. And then finally, just be aware of the fact that there are a lot of other ways there are advances in ambulatory assessment now. Ambulatory heart rate can be assessed on a continuous basis, and you can do this using there are bands that you can wear around the chest for measuring ambulatory heart rate. There are also multi-channel ambulatory devices that can assess even impedance cardiograph signals, respiration, and other parameters as well. And much of this work is being done by some of our European colleagues. And here are here's a nice reference to some colleagues of ours in the Netherlands that have an impedance ambulatory-based impedance cardiography unit. And then there's this new device that just came out that's used primarily for medical instrumentation. I can't vouch for it. I think it's an American company, and it's usually it's designed to assess things like respiration and blood pressure using not with a cuff actually. I think this is a kind of a wireless. I think it may be a wrist-based unit. I'm not sure, but I thought this was an interesting device. You may want to look that up as well. I think that's it. Oh, okay. And then here's just a couple other references. This is a handbook of behavioral medicine that came out in 2010 that has some nice chapters on measurement. This is a classic on cardiovascular psychophysiology by Paul Obrist, who was kind of the pioneer in this field, who kind of got people started in terms of interest in cardiovascular reactivity and what it means. This is published in the 1980s, but I think it's a very simple read and is really incisive in terms of thinking about some of these issues. And then finally, I have a couple of web-based references here in terms of if you want to get started. Biopack systems, if you're interested in putting together some laboratory measures of cardiovascular activity beyond an oscillometric blood pressure unit. BioPAC systems can get you started if you already have some training in the area. If you don't need training and you need somebody to set up your lab and walk you through everything, even if you have a kind of a complex set of protocols that you're interested in, if you have some startup funds, Mindware is a very good resource, and you might want to look at this this reference here as well. It was actually started by Gary Burnson, who's a psychophysiologist at Ohio State. They have a lot of kind of preset parameters that measure things like impedance cardiographic landmarks and so forth that are really based upon good scientific evidence. So I don't mean to be a salesman, but that is I can vouch for the scientists behind the Mindware anyway.
Well, great. Thank you so much, Tom. That was really informative. We do have another question here.
Okay.
The question is, in clinical controlled experimental settings, what are good practices for controlling posture and activity during blood pressure measurements?
You want people to be sitting upright with their feet on the floor. You don't want people to cross their legs because that will result in some pretty major vasoconstriction in the legs, which can affect blood pressure, systemic blood pressure. And you want your arm to be at the heart level when you take the blood pressure. You don't want people to be talking. There are some good there is a reference by Perloff, P-E-R-L-O-F-F, with, I think it's American Heart Journal in the 1980s, that talks about good practice for assessing blood pressure. If you are doing blood pressure assessment in a laboratory, I do suggest that you train people very carefully. You train your research staff. There are a number of good YouTube videos actually out there now that do a fairly good job of walking you through what this looks like, what you need to tell participants, and how you need to interact with them. And if you're selective in terms of the kind of the sources that you're using for these YouTube videos, I think you can get some pretty good training by making use of those.
Great, that sounds like a good idea. So speaking of YouTube, we are out of time, but if anyone wanted to revisit any parts of this presentation, you'll be able to find this video on YouTube on our SPH Network channel at a later date. I just want to say thanks again so much to Tom for his very informative presentation, and thanks to all of our attendees for joining us and asking some great questions.
Thanks, everybody. I hope it was helpful.
Thank you.